Please help me welcome Randy Kojima.
And thank you to the whole team at Valley Contax for having me down here tonight to share with you some thoughts about how we use the topographer at the university, how we use it to analyze patients, how we use it to build our contact lenses, how we use it to help us be more efficient in practice. So let's start with the topography. Have a look at this corneal topography. What would you say this eye is? If you didn't know anything about this case, when you look at that map, what would you presume that you have? And I think it might be safe to think it's something like post-refractive surgery, maybe an intact put in here, or a post-LASIK ectasia. This is actually just a poorly fitting GP lens that is flattening the corneal apex and creating a bit of a smile there. So when this patient came in, new to the practice, we saw these horribly flat-fitting lenses. And this is an axial map, an axial interpretation. An axial is the best way to understand power or refraction. But if you want to understand how does a contact lens affect shape, you use something called a tangential map. Now, here again is another axial interpretation of the same patient, but notice what's happened is we now have the normal figure 8 astigmatism starting to develop by taking the patient out of this poorly fitting GP lens and allowing the cornea to normalize. We're able to observe in our axial map that beautiful with the rule astigmatism, fairly symmetrical, the inferior and superiors looks like it's a mirror of one side or the other. Now the question is, when you look at this axial map, is our RGP still molding the eye? Is an axial map sensitive enough to see those finite little changes? This is a tangential map. Now you use the tangential map when you want to understand shape, when you want to understand how is my GP lens affecting the shape of my eye, or how big is the cone if it's a keratoconus patient? Where is the cone? So look at these two arcs here. Doesn't this look a little too mechanical to you? It's a perfect mirror on either side. And we know eyes aren't utterly symmetrical. So the tangential map is great when you want to pick up finite changes in the corneal surface. So axial for refraction, tangential for shape. Now here's the same patient another month after refit into a brand new parameter, a brand new Valley Contax toric lens. And the question would be, when you look at the axial map, do you see the normal figure 8 astigmatism? Can you presume that our lens has appropriately vaulted the corneal apex? And I think because we see this nice figure 8 astigmatism, we can say our lens is likely appropriately vaulting the apex. The eye is smooth and it's normal in its astigmatism. When we pull up the tangential map, that might tell us if our lens still has some molding. And RGPs mold the eyes. We hope they mold them in very small ways, but it's typical for some molding to happen. But look at your axial map immediately after removal. You can imagine the kind of spectacle blur this patient would have from this flat area immediately within the pupil, then a steep area. So axial for power. Then we allow the eye to normalize, then we refit the patient, and has our lens altered the shape? I think if we pull the GP off this eye, we wouldn't have the spectacle blur anymore that we did here. But when you pull up the tangential map after that refit, you can see where your lens lands. That tangential map is very sensitive to those finite points of pressure. And this is normal. Our GPs sit on the cornea, they create some mechanical pressure, but the point is, use your tangential map when you're interested in how is my lens affecting corneal shape. Use the axial map when you want to relate the shape to refraction. So here's our patient. Axial map immediately after removal of our poor-fitting GP lens. There's the tangential map. Notice this abnormal, these arcs in the surface of the eye, a bit of a flat spot running right through the center. So the tangential map is very sensitive to those alterations in shape. Then we refit the eye. Notice the tangential map shows a very smooth center now where it didn't before, but you pick up these little arcs, and that's what you might look at. Now have a look at this keratoconus patient, and here's an axial map would you presume that this eye has been altered in any way, shape, or form by an RGP lens? And all I can say from this axial map is I've got a power in the neighborhood of 58 diopters in the pupil, and I've got a power of in the neighborhood of 36 diopters within the pupil. So there's a 22 diopter power scale range within that pupil. So axial map tells us refraction, right? How do we relate the anterior surface shape to refraction? And that's what the axial map is telling me. But do you see anything funny in this topography? Is there something unusual that the axial map might slightly be picking up, but that isn't so obvious? And it's this. Even in a keratoconic patient, corneas are smooth. Notice how the rings appear to be pulled a little bit here and here, a little bit in there. So this is where the axial map is not so sensitive. So axial we use for refraction, but if we want to understand, is our eye altering shape, we pull up the tangential. Where do you think that contact lens is positioned? Small, steep lens, fitting right over the cone, kind of locking itself down around the cone, and it becomes immediately obvious where our lens is bearing, where it's positioning as well. Not that we wouldn't see that in the slit lamp, but you can tell from tangential maps how you alter the shape of the eye. So here's the patient refit into a larger diameter lens, and there's our axial map. We can see the distribution of power goes from 36 to 56 diopters. So we went from 36 to 58, now we're 36 to 56. We haven't changed much within the pupillary zone. It's a keratoconic patient, we're not expecting to change it, but the question is our GP altering the shape of the eye? So let's go from an axial interpretation to a tangential, and now we can see where our lens is positioned. Went to a larger diameter valley lens, and now we're using the whole cornea to center our contact lens, not have this small steep lens that's just fitting the cap. We're going larger in the eye cone lens. So comparing the maps, here's your axial map, here's your tangential map. There's immediately after removal of our small steep lens with the tangential, and here's our larger diameter with the tangential. So when you want to understand power, refraction. When you want to understand shape, tangential map. Now, we're real sticklers at Pacific U about good quality imaging. It doesn't matter if we're talking about topography or any field analysis or anything. We want good imaging, whatever we're doing. So number one of the easiest things that we can control is getting the patient open up as wide as they can. Not everybody can open up the fissure, but we try to do the best job that we can, and we teach our students to get those patients to open up as much as possible, because it's not just the upper lid that's cutting off the reflection of these rings. It's these eyelash shadows also coming down and blocking the reflection of the placido disc. So do the best job that you can. Now this is the same patient with our small fissure, then with our large fissure. Notice how different the astigmatism appears centrally on this axial map versus our fissure-sized open right up. And really, when we get the lids in the way, it can really hinder the interpretation of what's there. The topographer has to do a lot of guess along this border where the eyelashes are coming down. So again, just try to do the best you can, get your patient open up as wide as possible. Now, especially on the Asian eye, we have smaller fissures. There's not a lot we can do to get the patient to open up. So what we'll do is we'll ask them to bring their chin in, forehead back, and then reach around the forehead rest and then pull down on their cheek. We can't pull back the upper lid because then the patient can't maintain normal tear flow, but we can pull down on the lower lid and just open up the fissure just a little bit more. And this is what we did here. Notice how we've got good pulling away of the upper lid, but the lower lid is blocking maybe 20% of the inferior cornea. So just asking the patient to reach around that chin rest and just pull down on their cheek just gives us a little more information. And although most RGPs will bear across the horizontal meridian, the flattest corneal meridian, we want to know before we design the lens how much depth exists up here and down here. Is there something that's going to hinder good movement, good tear pump of the lens along that vertical meridian? So really important. Now consider that a corneal topographer, a placido-based reflection system, does not actually measure the cornea. And I know that sounds crazy, but a placido-based topographer reflects off the tear film. So this may be hard to pick up in the video, but you can see these little breakups where multiple rings are coming together and collapsing. So that's tear film breakup. And placido-based topography, one advantage is that you can measure tear film breakup. Have the patient blink and then just count seconds until you see those little distortions in the placido reflection. But the bad side of these breakups is that it causes topographical error. The topographer goes along each one of these points and it says, I can read it, I can read it, I can read it. As soon as it hits an area where multiple rings come together, multiple points collapse on each other, the topographer is going to lie. It's going to miss, it's going to guess. So we want to take that guess out as much as we possibly can. Now sometimes we can't put in artificial tear and smooth out the rings. We can't ask the patient to blink frequently enough. And this is an example where we have an inferior area of scarring, and this is an RK patient. And it doesn't matter how much fluid we load this eye up, we won't smooth that over. So don't be surprised when you've got cases that you ask the patient to blink, you put in artificial tear, and nothing seems to work, and this will be one of them. Patient with keratoconus with a large area of scarring, a patient that had penetrating keratoplasty, examples where we just can't smooth out the placido. But what do we do to smooth out the placido so we can understand what to use? And what we do is put on a real thin lens, a real thin daily lens, maybe in a +1 power. So once you put the soft lens on, then that will smooth out that area of scarring. The placido can reflect off of it, and then you can determine the shape and elevation of the eye. At least the topographer won't be guessing as bad as it would with a heavy area of scarring. You know, here's an example where the central rings are utterly distorted, and a corneal topographer builds the shape and the elevation of the eye from the center to the periphery. So if the center stinks, you have no idea if you can trust the rest of the topography. So this topography here, derived from that placido reflection, is basically useless to us. I don't know if we can trust it at all. The only thing I can say is, here's where my lens bears, right here, and it seems like it has a bit of lateral movement. It's bearing in here, bearing in here. You can see that in the flattening out of the placido reflection. But otherwise, this topography, we don't know if we can trust at all. So put on a real thin soft lens. We usually use a plus lens because we'd rather think the cornea is higher in depth, so we build a lens slightly on the steeper side rather than slightly on the flatter side and maybe get touch. Now here's a patient that you can see some central scarring here, this ectasia that we had, and it didn't matter what we did to try to smooth out that placido reflection. So here's a case where if we were to put a soft lens over top, we get a much smoother central reflection, we get a better idea of what's there. So when you compare those two, if you click your cursor in the center, without the contact lens on, with all that scarring, the topographer thinks the apical radius is 49.5. Putting on a low +1 diopter soft lens, the topographer now thinks the apical radius is 56 diopters. So there's a 7 diopter difference between these two images. And it's purely because the scarring caused a lot of distortion in the placido. So one thing that we teach our students is never ever trust your corneal topographer. It lies to you constantly. And what you want to do is make sure that you know when it's lying and when it's not lying, or at least do the best you can. Now here's an image of a central ectasia, right? And you can see how pronounced this ectatic condition is. Well, this was actually a normal, healthy eye. So why did the topographer come up with this central ectasia? And here's the actual shape of the eye. And sometimes the topographer burps. It doesn't matter what, if you're using a placido-based topographer, sometimes it's going to burp. Now, why does it burp? Why does it make that error, that extrapolation error? And it's all to do with tear film. So when you watch these slides, each one of these is 0.6 seconds. So every 0.6 seconds, we took an image. And notice how different the topographer interprets the shape of the eye every half a second, basically. Now, why is that? Why does it look at the eye differently with each half second? And it's because a placido-based topographer measures the tear film. It doesn't measure the cornea. So we see the tear film moving across the eye and constantly changing our understanding of the shape. So that leads us to question, how do we know we can trust one single topography? So have a look at these 4 images. Which one of these maps would you presume is the real shape of the eye? We've had a patient with pretty quick tear film breakup, and I'm not sure which one we can trust. We might look at this image and say we've got a couple little flat spots, a couple little tear film thinnings or breakups. This one here looks like we did Ortho-K, or we have some kind of refractive surgery. The center of the cornea is applanated. This one here, you can see this channel where the tear film was thinning out in the center. So we just waited too long in between blinks before we flashed that image. This is probably the only topography we trust. But the point here is take multiple images on each patient, and that way you can say, looking at the 4 of these, which one has the biggest fissure size, which one seems to have the smoothest contours. We know corneas are ultra smooth, so we don't expect to see these holes or divots or flat spots in the eye, especially if it's a normal eye. How about here? If you were to look at these 4 images, which one would you choose to design your first GP lens that you were going to order from Valley? And we might look at image number 1 and say it looks like we've scooped out the center. We've got a flat spot there. This one here looks like a bit of tear film thinning, so the tear film is thinning out. This one here has a couple hot spots in the surface. So is that the real shape? Do we have 2 little steep areas of curvature? I might trust this one the most, although this appears to have a bit of thinning. If we had multiple maps that showed that flatter area in the same spot, then we can presume it's the real shape of the eye. What do you think this is down here? Notice how it's not really on that image. It's not as steep or as curved. That may be tear film wedging up, and that's a good reason to have the patient pull their cheek down when you're imaging, just to get any tear film wedging, especially if you put in artificial tear. Now we've really loaded up the eye with fluid. Now have a look at these 4, all the same eye, all taken within seconds of each other, same as the previous images, and we've got this real hot spot up here. And is that the real shape of that eye? But you see it 4 times over, and every one of those images looks very similar to each other. So this is what we like to see, is reproducible imagery. If we have reproducible imagery, we presume that we have the real shape of the eye. Therefore, when we email the maps to Valley Contax to design a lens, they know they can trust the maps. You know, if you design the lens from the maps or assess the patient, you can trust the data. So here's a question. This is something that it's taken me a long time to understand, that, and the team at Pacific has been real helpful in helping me to understand it. If you look at this eye, what would you say is the highest point? We have an oval keratoconic patient. If we took some options and said, is this the highest point, or is this the highest point, or is this the highest point, or is this the highest point? I'm sure if we had a show of hands, 100% of people would say, that is the highest point on that eye. It's a keratoconic patient. It's the steepest, reddest, most curved point on that surface. Well, let's drop a theoretical lens, a theoretical RGP, and assess the fluorescein pattern. And what the GP, or the theoretical GP, is telling me is, yes, this is a high point on the surface. When you run this white axis line through this meridian and look at the tear layer up at 12 o'clock, and then right through the apex, somewhere in here, just over the cone, very thin amount of fluid, and then lots of inferior edge lift. But this is a high point, but so is all this. So how's that possible, that this area is high and this area is high? This is the reddest curvature, this is the bluest curvature. Does that really make sense? So let's put the actual lens on eye. So we designed our theoretical lens with just a tiny little apical clearance, put that lens on, and it appears our lens is bearing here and here, where the axial map is saying the eye is fairly blue or flat in curvature. Now, how does that make sense? And if you're a little bit confused, then you're probably like me. So let's look at another case. Let's pull up another oval cone and ask ourselves, what is the highest point on this eye? So we have an option for the flattest, maybe one of these 2 points. the steepest area or just inferior of the cone, and I think it would be safe to presume we all want to say that red area. Well, let's build a theoretical lens and drop it on this patient. And the theoretical lens is saying the two highest points are here and here, where the Placido topographer is telling, or the topographer is telling us, that's the bluest area. This is the reddest, the most curved, the steepest area. So what are we seeing here? We're seeing that the topographer is telling us the eye is curved. It's curved a lot, but is it curved up like a volcano, or is it curved down like the edge of the cliff? So the topographer lies to you to a degree. We've been trained to think red is steep, it's high in elevation, it's a mountain. But sometimes it's the edge of the cliff. It's a curved point, but it may be curved down, it may be curved up. So let's put on the actual lens and drop it on this eye. Same lens we designed in the theoretical software, and you see the two highest points where our lens bears the most, and where the topographer is red, here where the cone is, this area is where the eye is bending. It's curved, it's red, it's steep, but it's not red, curved, steep coming out. It's red, curved, steep going back toward the back of the eye. So it's really a valuable thing to understand that axial and tangential maps say the cornea is curved, it's red, it's steep, it's curved, but it doesn't say up or down. And it can be a tricky thing to get your head around. So axial maps say curve, but they don't talk about elevation. And this is where we use in the topographer software the elevation map. So this is the axial map on our oval cone patient. Here's the elevation map on our oval cone patient. And what is it telling you? Red is where the eye is high in elevation. Blue is where the eye is low in elevation. So let's talk about that a little more. Let's take our axial map. You can see your cone inferior of apex. Where you see red on the elevation map, that's where the eye has a high elevation. Where you see the blue down here, that's where the eye is low or dropping in elevation. So what we're doing is we're putting a theoretical spherical contact lens, dropping it on this eye and saying if that lens hits the surface, where is the cornea high in relationship with the contact lens? Where is it low? So another way to think about this is to do OCT, ocular coherence tomography, and then that's the patient's OCT and in cross-section running across this vertical meridian. The yellow that you see here, that's your theoretical sphere. So you put the sphere on, and where you see the OCT or the cornea is on this side of the yellow sphere. It's on that side of the sphere. That's where you see red. Where you see the blue down here, that's where the eye is depressing away from the sphere. So elevation maps are great for telling us where is the eye high, where is the eye low. Now, in reality, at Pacific, do we use an elevation map routinely? Axial is the map we look at almost 100% of the time. Do we ever pull up an elevation map? Not very often. And the reason is, if we ever care about elevation, it's probably because we're putting a GP lens on. So if we're doing that, we'll use the contact lens software. But it's really important for practitioners to understand that an axial and a tangential map say the eye is red, it's curved. They don't say it's red, curved up or down. Same with blue, same with flat. Now here's a patient that comes in to see you and they're interested in refractive surgery. Is this a diseased eye? Is this a formed frust keratoconic? Should we be sending this patient along to the refractive surgery center? So what do we look at in our corneal topographer to tell us go or no go with refractive surgery? And one of the things that's most powerful to the surgeons is the IS value. Stands for inferior versus superior average curvature. So you take all the inferior points of data and average them out into one number. How steep or flat is this inferior hemisphere? Then do the same thing with the superior hemisphere. In this case, the inferior hemisphere is around a half diopter, 0.42 diopters, steeper down here than it is up here. The threshold for disease is 1.5 diopters. So this patient, at least as far as the IS value goes, would not be considered a diseased eye. Now the next value is surface asymmetry index, and what it does is it looks at the powers across this line and compares it like a mirror to the powers on the opposing side. And then in this oblique meridian it does the same thing, comparing this side to this side. And the more asymmetrical the surface, the higher number. So 0 would be an eye that has absolutely zero asymmetry. I don't think we'll ever see that in our career in eyes. But this patient has 0.85. The threshold for disease is 1.0. So this patient is still below the threshold in both these indices. Now the last value you might look at is surface regularity. And what it does is it looks just within the black pupil, where the topographer thinks the pupil is, and says, do I have a bunch of wild distribution of power that would create aberrations for the patient? So for instance, if I click on 2 points, we're 4290 up there, we're 4460 down there, a difference of around 1.7 diopters. That's not so severe within the pupil. With the keratoconic eye, we might see 20 diopters of range, of scale range within the pupil. That would be severe. So an SRI value of 0.8 or greater would be indicative of a diseased eye. So notice how all these numbers, the higher they go, the more abnormal the eye is. The closer to 0, the more normal the eye is. So threshold for the IS is 1.5. Threshold for surface asymmetry is 1. Threshold for surface regularity or of disease is 0.8. Now one thing that we do at the school that is one of the quickest and easiest ways is just look at the scale range here. If you set your topographer to something called a normalized scale, meaning the scale starts with the flattest it can read on the topography, making that the lowest number that it can find on the topography, and then making the steepest, the hottest color, the steepest it can find. So you see the full distribution of power on the axial map. And this patient goes from 37 diopters to 44. So if I've done my math right, there's 7 diopters of power distributed across this eye. Normal corneas fall within 10 diopters of scale range. So is this a diseased eye? No. Is it a slightly abnormal eye? Maybe we could argue yes, but it doesn't look like we have a diseased cornea, at least in terms of the anterior surface. We certainly haven't measured pachymetry, we haven't measured the posterior surface shape, but as far as the anterior surface goes, not a diseased eye. Now have a look at these 3 topographies and notice the amount of corneal astigmatism. 1.5 diopters, 1.37, 1.25 diopters of corneal astigmatism. So if we did keratometry on these eyes, what would the keratometer tell us about the corneal astigmatism? This eye has the most corneal sill. This eye has the least corneal sill. If I asked you which would be the most complex eye to approach, which one were you going to say? You're probably going to say the keratoconic patient, which would be the easiest, the symmetrical, apical, with the rule, perfect astigmatism that's very centralized. Is this a slightly tougher eye to fit? Yeah, because you see the hot meridian going almost from one side of the eye to the other. So this is what's called your limbus-to-limbus or pseudo-limbus-to-limbus astigmatism. This eye works very well in a spherical GP lens. This eye just may need a toric periphery or maybe even a toric. It's possible. It's a low amount of sill, but it's possible. The point is, if you were using keratometry or K readings as a way to build a GP lens, would that make sense when K readings are taken at 3 millimeters and we have 2 data points? Or should we use the topographer with thousands and thousands of data points, building the shape and the elevation of the eye, allowing us to drop a theoretical lens on and observe its fit before we put the patient in the slit lamp? So another way to think about this is, let's think about the eyes not in terms of central astigmatism. Let's think about them in terms of depth. Now, if you look at these 2 corneas, we have apical astigmatism and limbus-to-limbus astigmatism. Notice how the hot contour runs from one side of the eye to the other. This patient has 1.3 diopters corneal sill. This patient has only 0.9. So you'd presume in corneal sill, this would be an easier eye to fit. But notice how that hot meridian runs from one side of the cornea to the other. How is that different than this eye that seems to have this symmetrical green all the way around? So let's do something different. Let's think about corneas in terms of sagittal depth. So we'll pull up in our MedMont the sag values that it gives us. So in the flat meridian, this eye measures 1,476 microns. So what are we measuring? We're treating the cornea like a mountain and saying, how high is the mountain? And across the horizontal meridian, this eye measures 1,476 microns in height. Now on the vertical meridian, it measures 1,509. There's more depth to the vertical because that's the steep corneal meridian, right? Now let's go to the limbus-to-limbus astigmat. Let's pull up the sagittal depth of this eye, 1502, 1556. So what's the difference between these two? Remember that this eye has more corneal sill, 1.3 diopters. This eye has only 0.9 diopters of corneal sill. But the depth difference between this axis and this axis is 33 microns in our apical astigmatism, but there's more depth differential with our limbus-to-limbus sill. And for practitioners really familiar and comfortable with fitting GP lenses, why is it that one patient with 2 diopters corneal sill fits very well into a spherical GP and the next patient with exactly the same corneal sill needed a toric? The lens was grossly unstable. And it's the difference between apical astigmatism and limbus-to-limbus. And keratometer just doesn't tell us what's going on inside of 3 millimeters or outside of 3 millimeters. So really powerful stuff when we understand the depth of the eye in the principal meridians. Let's look at this another way. Let's drop GP lenses on, just 9.5 diameter lenses. And here's our 1.3 diopters corneal sill. We land the lens at 3 and 9 o'clock. So you see that on the graph. There's your edge lift at 9 o'clock, landing at the optic zone junction, up to our apical clearance in the center, then landing at 3 o'clock, and then your edge lift. Now notice on both the apical astigmatism and the limbus-to-limbus astigmatism, you've got the same profile of fluid underneath the contact lens. So nothing exciting there. The two eyes are identical, and that's because they have almost the same flat K. So we put on the appropriate lens, it's going to look the same in the horizontal. Let's take our axis line to the vertical and look at the fluid underneath the vertical meridian. When I click my cursor at the optic zone junction, we're 31 microns heading north, 20 microns heading south, 51 microns of total fluid underneath that lens at 12 and 6 o'clock. In our limbus-to-limbus astigmatism, with less central corneal sill, we actually have more total fluid underneath the lens. And it's strictly because we're not dealing with an apical astigmatism. We're dealing with a limbus-to-limbus astigmatism. So this eye has far more depth, far more curve from the center all the way to the periphery. So in orthokeratology, for instance, when you're looking at a potential case, you always look, is it apical or is it limbus-to-limbus? Because if it's limbus-to-limbus, you need a toric. If you're fitting a patient with a GP lens for single vision, for multifocal, you look at, is it a apical astigmatism or limbus-to-limbus? Because you may need to go with a toric if it's limbus-to-limbus. Now, let's talk about maybe what might be the most powerful part of having a corneal topographer in your practice, or at least at Pacific U, we feel the most beneficial reason to have a corneal topographer is its contact lens module, how it helps us predict the first lens. So let's review how we come up with a lens. We take a topography, then we drop on a theoretical lens, then we decide if it's the appropriate lens, and then we put on the actual trial. So our trial lens actually goes on first in a theoretical environment before we put on the actual lens. So one of the things that we need to consider is, what do we know about fluid, about fluorescein underneath the lenses? And if in my training, I've always been taught to think about fluorescein in very relative terms. It's acceptable, it's inadequate, it's excessive. But have you ever been taught to think about fluorescein in microns, in any absolute values? And we just haven't. And that's because it's pretty tough to assess. For instance, does that lens have central touch? Is that light green we see over the center optic zone of this Ortho-K lens, is that on the anterior surface or is it on the posterior surface? It can be tricky to tell. You might say that looking at where the lens bears, this looks darker than that. So is the lens slightly clearing the corneal apex? Kind of tricky to tell. How much fluid is underneath here? In an Ortho-K lens, we want about 50 to 60 microns of fluid in that reservoir. Is that 50 to 60 microns? No idea. Studies say that RGP lenses should have edge lift of about 60 to 90, 60 to 100 microns at the tip of the edge. How much fluid is under the edge? It's so hard to tell. Let's look at a normal single vision GP and drop it on eye. How much fluid is underneath the apex of that lens? How much edge lift exists? And we just can't tell from looking at fluorescein. It's pretty tricky. So one of the things that's helpful, or at least was helpful for me to understand, was that fluorescein is visible when you have 20 microns of fluid and fluorescein molecules. So in this case, if we took this white axis line across a theoretical GP dropped on eye, there's your edge lift in the neighborhood of 100 microns. Then it comes down to 20 microns and dips below where that lens lands on the corneal surface. So this area here, we can't necessarily say how much is bearing and how much is just that dropping below our threshold to pick up fluorescein molecules. You see, this point of bearing is actually quite acute, but you're going to have this entire distance from there to there, this distance of where you wouldn't be able to see fluorescein molecules. So it's important to know that we have some limitations with fluorescein. But if you want to build your lens so you can say, yes, it definitely clears the corneal apex, you want 20 microns or more under the center. That's rule number one. Now when you drop the actual lens on that we just designed, notice how that lens drops below our threshold in here. That's this area here. Then we come above 20 microns throughout this entire central optic zone, and then you see your edge lift at 3 and 9 o'clock here and here. So that's how we build the lenses. Now, if 20 microns is your minimum threshold to pick up fluorescein, what's the upper limit? And in this case, if we took this keratoconic patient and run the axis line through the vertical, that's 12 o'clock right here, and then we seem to be over 100 microns right in here. Then we come down to near touch, near to the cone, and then our inferior lift. Now at 90 microns, that's the threshold where a bubble can form. So if you're building a GP lens from your corneal topographer, make sure you stay below that 90 micron threshold, or a bubble may create itself. So here's the same actual lens that we designed from that pattern, and where do you see the bubble? Exactly where we've got that in excess of 90 microns of fluid. So very powerful stuff. Now let's start to think about rigid lenses in relationship with this kind of construction. But before we do that, what we want to do is take an optimal capture for GP lens design. And notice when your patient fixates down the axis of the instrument, the topography seems to be skewed off, this is a right eye, to the nasal side. So you see all this blue here. Now if I ask the patient to look 1, 2, or 3 rings in toward the nose, now I can push the placido onto the geometric axis of the eye. So if you think about this another way, because our fovea is temporally displaced, when your patient looks down the axis of the instrument, they're always looking out. So you photo the nasal side of the eye with each image. And what we want to do is land the placido on the geometric axis so we can build the contact lens on the geometric axis. Because that's, of course, how we fit the lenses, right? Through the slit lamp. We don't look at the fitting of our contact lenses in relationship with the visual axis. We don't know where the visual axis is when we're looking through the slit lamp. We do, however, can see the iris, and we fit our lenses based on the iris. So here's an example of patient looking right down the axis of our topographer. Notice how the rings seem to hit the nasal side. We get more color on the nasal side. We're missing some iris out here. So that's imaging on the visual axis. That's the normal way patients would fixate. But maybe not so helpful for us when we design GP lenses, because we may have this artifact out here that could hinder the accuracy of the design. Now when we ask the patient to fixate 1, 2, or 3 rings in toward the nose, now you can see the topography looking centered to the iris out here. And when we drop our GP on, we can see we've got some symmetrical shape that we can probably land our lens on. So a much better way of imaging for GP lens design. So if you're going to send maps to Valley Contax, make sure that you have, make sure you image on that geometric axis, because the visual axis isn't so important to us in terms of building the lens. Certainly it's important where the visual axis is in relationship to the optics, but in designing the optimal lens, we want to design it based on the geometric axis. So here's an example of how you might fit or build a lens for a patient. Pretty tough cornea. We've got 2.8 diopters, or let's call it 2 3/4 diopters of corneal astigmatism. Maybe that's not as concerning as the against the rule sill. And where would we expect in an against the rule eye a rigid contact corneal GP to land its heaviest? 12 and 6 o'clock, right? So I'm worried right off the bat that we may not have an optimal GP patient here. So across the flattest corneal meridian, that's where we expect the lens to bear the most. And this may not be so good. If you look at the flat meridian running vertical, when we drop the spherical GP on this eye, what happens? It hits heaviest at 12 and 6 o'clock, 12 o'clock, 6 o'clock. So then what happens in the horizontal meridian, the steepest meridian, where we have the most curve to the eye? We're going to have all this fluid vaulting. So as we go from center to periphery, the fluid thickness is getting thicker and thicker and thicker in both meridians. So what do you think will happen? What is the topographer telling us is going to be the movement and position of this lens? With each blink, instead of sitting at 3 and 9 o'clock and moving up and down and pumping fluid appropriately, we're probably going to be driving the lens into the ear or into the nose. So here's the actual lens designed by our topography, and you can see how similar the patterns are. Using your Medmont to design lenses, it's a one-to-one if you've got good topography, and I'll repeat that one more time. If you have good placido reflection, it's one-to-one. If the placido reflection is terrible because you've got scarring, it's not going to be one-to-one. But if it's a good image, it is wickedly accurate. Now here's the actual lens that we fit on this patient, and you can see the spherical GP and how poorly this lens is fitting. Have we cleared the corneal apex? Yes, this is good. We're protecting the central epithelium. That's optimal. Our lens is landing at 12 and 6 o'clock. It had to land somewhere. This is an against the rule astigmat, so of course it's going to land across the vertical meridian. But of course the problem is that we have nothing to keep it on lateral center. So this patient may not be a good candidate for GPs. But what if we were to take all this toricity that the patient has in the astigmatism, 2 3/4 diopters of corneal sill, what if we use that astigmatism to our advantage? So let's create a lens that has a steeper horizontal meridian than its steep K, and let's create a flatter vertical meridian where our cornea is so flat. So let's back up, I'm sorry. Across the horizontal meridian, we're going to fit a base curve that's steep enough so that lens lands at 9 o'clock and lands at 3 o'clock. Then in the vertical meridian, we're going to fit a base curve flat enough that that lens will lift off, running all the way through that vertical meridian. So notice the fluid layer running all the way across. 0 is the corneal surface, and what you're looking at is the fluid layer underneath that lens. So we've got this nice little channel now. Maybe this lens has hope of working. And there's the bitoric lens fit to this high against the rule astigmat. Now we've got a lens that wants to center. So let's have a look at the video and see how well we did. Instead of having a lens that hits at 12 and 6 o'clock and only goes nasal and temporal, now we steepened up the horizontal meridian so it can only sit on these rails. It can only move in the vertical meridian. So a powerful tool for helping us to optimize the fit of the lens. Before we started, we knew that a spherical GP on this patient had no hope of being successful. We needed to go to bitoric. Would the bitoric have hope of landing? And it looked like it did, so we ordered the lens from Valley, and there's our fit. And this patient loved this lens because as a high against the rule astigmat, with the typical rotation you see on those soft toric lenses, the GP had very stable vision, as you can imagine. So when you fit GPs by corneal topographer, you use the theoretical environment to determine the best first lens, and then you drop that lens on eye. So in this case, we had a keratoconic patient that had good landing at 3 and 9 o'clock, but in the vertical meridian, we had over 202 microns of fluid down here at 6 o'clock. So right off the bat, we were concerned that maybe a corneal GP may not be the way we want to go. Maybe we want to pull out a scleral lens for this patient. But we had a good horizontal meridian, so we thought, well, let's just give it a shot. It doesn't look like an optimal scenario, but it doesn't look like it has no hope either. So here's the actual lens we put on this eye, and you can see how the two match. This is a keratoconic, a very advanced cone, and you can see how the two match. The only difference is that we have lid force here pushing the lens, tilting the lens against the superior cornea, so you have this arcuate area of bearing where you don't see that on the theoretical lens. This patient was lucky. He had that smaller fissure and was able to support the lens at 12 and 6. For whatever reason, didn't get the bubble underneath it at 6 o'clock, so we didn't need to go with the scleral lens. On the fellow eye, we did need to go with a scleral lens. The cornea was too asymmetrical. We had all kinds of bubbles underneath the lens. So the question you might ask is, okay, can we actually do this? Can we actually take a corneal topography and fit a keratoconic patient with this and expect the theoretical pattern and the actual to agree? And to understand whether that was possible at the University of Iowa with Christine Sint and her colleagues there, what we did was over a 1-week period, we took every keratoconic patient that came through the door and pellucid patients. So all the keratoconics, all the pellucids, and we mapped them, and then we designed up a theoretical lens and tested the actual lens. So could in this case, a Medmont, be used to design lenses even for the diseased eye? And what we found was when the placido reflection was good, when you had good quality placido reflection, the instrument was accurate 95% of the time. When the placido stinks, like this one does here, where you've got a lot of distortion of the placido, it wasn't very correlated. It was only accurate 12% of the time. So good placido reflection, and you can expect high confidence in the lens that you design for the patient. So that was a really good take-home for us because it told us when that placido looks bad, we might as well just go to the trial set and take the nomogram or the nomogram from the trial set to design the lens. When the placido looks good, then we use the topographer to design the lens. Now, let's talk about how we would take a case and move it forward. So here is a axial map on a patient, and there's the elevation map on the same eye. If you didn't pull up the contact lens software, what would this tell you? Would you presume that you need to go corneal GP, or could you go corneal GP, or are you more likely to require a scleral here? And what one might look at is the cornea is high, it's low, it's high, it's low. So there's a lot of asymmetry that exists to this eye. When I look at this axial map, what I would see is I've got a fairly symmetrical area of blue out here. I'm presuming I can land a rigid lens and have it align 360 degrees. The lens is probably just going to ride a little bit down and out on this left eye. But the axial map doesn't tell us elevation. And here's your elevation map saying the cornea is going to be high here, low here, higher here, not really high, but higher in relationship with these 2 points here. So there's some asymmetries here. I'm wondering, I don't know, is a corneal GP going to work? So let's put on a theoretical lens. So here's the theoretical lens across the horizontal meridian. So across this meridian, look at the fluid. Edge lift, landing at 9 o'clock, up to apical clearance, landing at 3 o'clock, and then your edge lift. Now here's the vertical meridian. What did we say is the threshold for a bubble? 90 microns, right? And look at the patient is off the charts heading south, off the charts heading north as far as fluid thickness. So how are we going to adapt a corneal GP to adequately fit this very, very asymmetrical eye? And here's the actual contact lens that we designed from that topography. And you see the challenge, just like the the elevation map told us. Cornea is high, it's low, it's high, it's low. So here, going with corneal GP, we should have trusted the topographer. The topographer told us you have very little hope here. We should just fit this patient with a scleral. And that's what we were forced to do because we don't have a contact lens that adapts in that way, has one meridian of curvature and then has high, low, high, low. So sometimes what the topographer tells us is what not to use, and that can be as valuable as telling us what we should use, because if we endeavor to fit this patient and we spend 20 minutes waiting for a GP to settle before we can evaluate whether it's going to work, we've just wasted that amount of chair time, wasted the patient's time. We should just have gone straight to a scleral right off the bat. So a really helpful thing, it's not just what it tells us to use, sometimes it tells us what not to use. Now here's a fairly advanced cone patient, and this is a patient that came into the school with a box full of lenses. They had 5 different cases, 10 lenses for their OU fit, and not one of them that they were comfortable in. And so the team, the typical scenario for the team down there, we wondered what could we do with this eye. So we pulled up the contact lens software and put on an eye cone lens and said, okay, what kind of hope do we have here? And you see how ectatic this cone is. It's a real high point. So when we drop that lens on eye, everything is hitting the cone and decentering. And that's why none of his contact lenses are comfortable. What if we were to go much steeper in the center and try to vault over the cone, try to land out here in the mid-periphery? So we went much steeper to try to push that bearing below the cone, but now we're up to 101 microns of fluid under the apex. So now what do we have? Now we got a central bubble. So this is a really tough patient for a corneal GP to work. So that led us to use this very experimental lens that is available through the Medmont topographer that is, again, experimental. We expect Valley Contax to be able to manufacture this sometime very soon. But what it allows us to do is take all these little handles, these little control points, and lift them where we want the contact lens to lift and drop them where we want the contact lens to drop. So across the horizontal meridian, I want to create about 80 microns of edge lift on either side. Then I want to distribute that force, that landing of the lens. We don't want it to come to an acute point of pressure. We want to distribute that force over as broad a surface area as we can. So we create this nice aspheric landing. Then we pull this handle up to create 20 or 30 microns of fluid in the center of the contact lens. And that's our horizontal meridian. So that would land the lens down at 3 and 9 o'clock, put it on these rails so it can't laterally shift. And then in the vertical meridian, what we want to do is when we drag this axis line to the vertical, we want to see a nice even fluid layer. We don't want the fluid getting thicker and thicker, creating a bubble, creating instability, excessive movement, and an uncomfortable lens. So we take all these little handles and we drag them up to somewhere in the neighborhood of 20 microns. So there'll be that nice layer of fluid all the way along. So here is a symmetrical keratoconic design lens. There is what we call a topography-derived shape lens or topography-derived surface. Now imagine which lens would be more comfortable for the patient. It's pretty easy to see that this is going to have a hard time centering, it's going to move a lot, it's not going to be very comfortable. If you didn't know what was underneath this theoretical fluorescein pattern, what kind of eye would you presume that is? You know, you've got landing at 3 and 9 o'clock, nice little channel running all through the vertical meridian. Doesn't it look like this is a with-the-rule corneal stigmat, a simple with-the-rule stigmat? But this is actually a fairly advanced cone, and that's because the lens is lifting where it needs to lift and dropping where it needs to drop. So here's the actual lens. And if you've seen a lot of keratoconic patients, you rarely see a lens with a pattern that looks like this, where you have perfect landing at 3 and 9. You don't have excessive inferior lift or bearing over the cone. And if you fit steep enough to clear the cone, then generally you have excessive lift just superior of the cone. So at Pacific, we're kind of excited about this technology, that maybe this is the future of corneal GP lenses for the diseased eyes. We know that not every patient can wear a scleral. We're as hot on scleral as everybody else is, and as the team at Valley is in terms of scleral. But we know the deep set eye is tougher to get those lenses in. We know a certain percentage of patients have persistent fogging that within minutes of putting the lens on, they just fog right up. That fluid layer just gets fogged up. So they can't wear a scleral lens. So this is where we think this might fit in. So excited about this future. Now the same thing is, could we adapt this to orthokeratology as well? Now here's a patient with 2 diopters of corneal cyl, but it's not just the central astigmatism, it's limbus-to-limbus astigmatism. And remember what we said about that limbus-to-limbus cyl. The eye has a lot more depth running through that vertical meridian. So when we put on a symmetrical Ortho-K lens on our high corneal astigmatism with limbus-to-limbus cyl, our lens bears at 3 and 9 o'clock, but excessive lift at 12 and 6 o'clock. So that lens is not going to work for this patient. So what if we were to use the topography-derived surface to design a lens? So across the horizontal meridian, we'll take all those little control points, bring the lens close to the central corneal apex without touch, have around 60 microns of fluid in the reservoir, land the lens appropriately at 3 and 9, and a good healthy edge lift. Then the same thing in the vertical meridian. Let's land the lens 360 degrees around. Now, why would we in an Ortho-K lens land it 360 degrees when in a conventional lens we want that nice fluid layer? And the thinking is an Ortho-K lens doesn't work in the conventional environment with tear pump, with movement. We close the eye over the lens. We want it to seal and trap that fluid in there. So we're going to create 360 degrees of landing. So here's our symmetrical lens dropped on this limbus-to-limbus astigmat, and there's your topography-derived shape. And notice how that lens has aligned itself to that very toric peripheral cornea, and that's how we create better centration. So kind of exciting that these kind of technologies can be adapted to many different applications. Now a question becomes, we're talking about corneal GPs, but boy, Scleral is just dominating the publications. It's dominating the symposia. So we're really moving in that direction, and certainly we can see at Valley Contax that's the direction that Valley's been moving with their big line of scleral options. So can we use a corneal topographer to fit a scleral lens? If the corneal topographer measures cornea, but the scleral lens fits beyond cornea, can it be used? So let's share some thoughts. Now, if we start with keratometry readings, we're talking about 3 millimeters, aren't we? We're taking 2 data points at 3 millimeters out and trying to come up with a scleral lens that's 15, 16, 17, 18, big, right? Is that going to be helpful? That's the question. Now, if we take this particular case, this patient shows they only have 1.3 diopters of corneal cyl, but if you click your cursor, one box, that's 1 millimeter, and maybe a third, 1.33 millimeters superior of the apex, it's 37 diopters. Heading south, 1 millimeter, 2 millimeters, almost 3 millimeters, we've got 52 diopters. So within 5 millimeters, there's, a 15 diopter scale range. The keratometer said that there's only 1.3 diopters of corneal cyl. So you can see how useless keratometry can be in some patients where we've got this ectatic condition that's just outside of where the K readings are measuring. So something to think about. Now, is a topographer any more helpful in fitting a scleral lens when it's only measuring cornea? It's not measuring out to where our scleral lenses land. And that's a question that our team asked. And led by Pat Caroline at Pacific University, he's really been pushing us at the school to understand the eye shape well past the cornea. And one of the first studies that we did out there was to use the OCT and observe what's happening beyond the cornea. So imagine this is 10 millimeters diameter across the cornea. And at around 10 millimeters, the eye begins to form a very straight line or tangent shape. So the eye actually has no curve through the limbus. You can see the limbus is somewhere in here where the density of molecules is very white, and then you get that grayer or blacker area. So the limbus is in here. Peripheral cornea, flat straight line, right through the limbus, right onto the sclera, and then at around 20 millimeters diameter, about 20 millimeters across, that's where the eye begins to form its eyeball shape, its curved shape. And you can kind of see that here, can't you? Curved cornea, and then it starts to form that straight line right there. So this might be helpful to us with corneal topography. Now, the next study that we did was to look at the 15 millimeter diameter and what is the average of these angles. Since we can't call it curved, how curved is the eye, how tangent is the eye. And at the 15 millimeter diameter, the eye has only about 1.7 degrees of differential. In other words, the eye is very symmetrical the closer you are into the cornea. When you get out to the 20 millimeter chord, the eye has 6.6 degrees of differential around the clock. So the bigger the scleral lens, the more likely you are to need a more toric type lens. The smaller you are, the less likely you are to need a toric. So this was really powerful to us. Why is there more asymmetry the farther we go away from the cornea? The belief is we get closer to the insertion point of the extraocular muscles. Maybe that creates that asymmetry, but it's not clear at this moment. So here's the 10 to 15 millimeter chord around the clock. Look how tight those angles are. But as we go out to the 20 millimeter chord, you see the asymmetry that's introduced. Now, that led us to focus in on this 15 millimeter chord and fitting lens diameters that land close to 15 millimeters. So that kind of covers a range of scleral lenses from maybe 14.5 up to 17 millimeters roughly, where the eye will be fairly symmetrical around the clock. So the next study was to look at what's normal. What are the normal angles in 55 normal eyes? Basically 55 students. And what we did was look at the nasal and temporal angle, and what we found was for normalized, the average angle is 38.4 degrees roughly. What do you think diseased eyes would be? Would they be higher in angle because we're fitting steeper base curve lenses to these eyes? Well, in 55 keratoconic eyes, the average nasal and temporal angle was 38.25 degrees. 38.4 degrees here, 38.25 degrees. The eyes are almost identical in their scleral angle. So that tells us we really don't need a massive range of different lenses to fit normal eyes and diseased eyes, at least as far as the landing goes. Now, for us, angle doesn't mean a whole lot. We don't fit contact lenses in terms of angle. We always think of contact lenses in terms of curve or elevation. So let's convert this to thinking about height. And from 10 millimeters to 15, the eye has about 2,000 microns of, the normal eye has an average of 2,000 microns of depth. The diseased eyes, very close to that 2,000 microns because their angle is very similar to normal eyes. Now, where are the eyes different? That's the question. And notice in the 55 normal eyes, we were around 1,750 microns was the average height of the cornea across a 10 millimeter diameter. And that's key because a corneal topography medmont will easily measure 10 millimeters. It generally measures 13 millimeters. So getting 10 millimeters of data is a piece of cake. Now, as far as the keratoconic eyes, they were around 200 microns higher than the normal eyes. So what this told us was normal eyes and diseased eyes are very similar in the sclera, but where they're different is in the cornea. So if our corneal topographer can tell us this, then we've got a big piece of the puzzle in building our scleral lenses. So we use what we call the scleral sag factor of around 2,000 microns as an average and assumed depth of the eye from 10 to 15 millimeters. Then we go into the medmont, we set the chord at 10 mils, measure the corneal sag, 1906 microns. We punch it into our formula. We take our corneal sag plus the 2,000 microns for that scleral sag depth, plus the amount of fluid we want between the lens, the back surface of the lens, and the cornea, and that tells us the sagittal depth of lens that we start with. So we use the corneal topographer to determine what depth of scleral lens do we need. We don't use the K readings that give us 3 millimeters of the center and really tell us nothing outside of that 3 millimeters. So a very powerful tool for coming up with the right first lens. Now, do we need a corneal topographer to fit a scleral lens? No, but imagine the typical first-time application of a scleral lens. If you're a brand new practitioner to scleral, or if you have a patient that is new to scleral lenses, you try to get the lens on without a bubble. Maybe you struggle, and we've all done it. Might take 6 attempts to get the lens on before you get it on without that bubble. So now you finally got the lens on and you find out you're at least a trial step out. So you got to pull the lens off and then go through the process again of trying to get it on. So if we could get the right first lens on the first time, it just makes us so much more efficient. So that's why it's so important to us. Now that scleral sag factor is really a good gauge, a good guideline to use, but it's not 100%. Here's an example. This patient has an angle of 38.6 degrees, so the angles of the sclera are fairly close to normal. So the depth is very close to 2,000 microns. So if we were to use that 2,000 microns, use the Medmont to measure the corneal sag, we're probably going to be in the ballpark. It'll work. Now what about here? What if the patient has a lower angle sclera? Now we're down to 36.5 degrees, almost a full 2 degrees lower in angle, and that makes the scleral sag factor much lower in this eye, 1,830 microns. How about the guy who's standing in front of you right now? I've got this really weird high angle, more like 42 and a half roughly degrees. Remember, normal angle is 38, and I'm 42, so that gives me a much more depth, 300 microns more depth in that 10 millimeter to 15 millimeter anterior segment section. So the scleral sag factor isn't going to be 100%. It's a good gauge, we use it all the time, but it's not 100% on 100% of patients. So that led us to presume, could we take our Medmont and measure corneal sag? But since we know the cornea begins to form this straight line or tangent shape, could we measure that angle and predict the depth of any scleral lens, any diameter, any soft lens sag? And that's what we did. We took the corneal sag measured at 10 millimeters, in this case 1,970 microns. Then we take the angle that forms right here. So when the cornea begins to form that very flat angled surface, can that angle here be used to predict a scleral lens well beyond that point? So we punch this into a little calculator where you have the topographer measured corneal sag, 10 millimeters, plus your corneal sag, 1,970 microns or 1.970 millimeters, the angle that forms, 36.3, the desired chord of bearing of our scleral lens, and that tells us we need a sagittal depth of 3,800 microns. So we take our corneal sag, 3,800, add in your apical clearance, and that tells us the lens we need. So there's a few approaches that we have with the topographer to help us best select that first scleral lens. Now, if we did one more step, what if we were to treat scleral lenses like we do corneal GPs? Could we create a theoretical model in the topographer? So let's use my eye as an example. I've got this really weird high angle, very normal corneal sag. Remember, the average corneal sag for 55 normal eyes was 1,750, and my corneal sag is 1,800 microns, so only 50 microns higher, and that's because I'm a slightly steep cornea. But I've got this really deep depth. Now, what does that mean when we drop a scleral lens on eye? So let's put in a theoretical scleral lens in the software. And this is a 16.5 millimeter diameter. And if I'm a typical visible iris diameter of about 12 millimeters, then at somewhere in this neighborhood, this is my limbus, right here and right here. And the software is saying across this white line, this horizontal meridian, this is the fluid underneath that scleral lens. And at the limbus, we're in the neighborhood of maybe 80 to 100 microns. We know scleral lenses sink on average 150 microns over the course of a month. 150 microns. So if that lens is going to sink into the boggy conj, and we only have 80 to 100 microns of limbal clearance out here, we're not going to have enough on my eye for that lens to clear the limbus. And the thinking is with scleral lenses is we want to vault the limbus. Because we don't want to mess around with limbal stem cells, we just vault over top as much as we can. So in this case, before I've even put a scleral lens on patient Randy, we can see that this lens may need some adjustment. So let's modify this fitting out here and put on a lens that would clear the limbus a little more. And so I can see before I've even put on this lens that by making that modification to this zone in the lens, we can now create somewhere in the neighborhood of 160 microns at the limbal junction. So we're kind of excited that maybe a corneal topographer that measures cornea could actually be used in a similar manner to how we select our initial corneal GP lenses. This needs to be proven out. It's very new, and we're presently at Pacific testing this nomogram to see if it actually works. But if it does, wow, do we have a powerful tool for selecting the initial scleral lenses. So question might be, why would you get a MedMont versus another topographer? There's a bunch of great topographers out there. What's the advantage of a MedMont? It's very contact lens specific. That's where its focus is. It doesn't measure pachymetry. It doesn't measure posterior surface shape. It's not a surgically oriented instrument. Does it help you design GP lenses, and is it accurate? Yes. And that's why Valley Contax has a MedMont, because they want to start with the right first lens the first time, reduces the exchanges, increases the comfort, increases the success for the patient. So that's why MedMont. And that's why we use it at Pacific, because it's accurate and because it helps us to fit our GP lenses. You can link a bunch of different instruments, the field analysis and digital imaging, the slit lamp camera, fundus, all into the same software. So you actually, within one patient file, have your topography, have your field analysis, have your slit lamp, have your fundus photography, all running off one single framework. So that's something that can be done with the MedMont. Now let's take what we talked about today and let's build a lens for a patient. Let's put into practice what we talked about. So here's a patient from Pacific U, and we've got our 4 images, and the first thing we look for is reproducibility. Is the topographer measuring the tear film the same each time? Is it therefore what we can presume to be the real shape of the eye? So look at this image compared to this, and compared to that, and compared to that. It looks like we have very reproducible data. Fisher size is all very similar for all 4 images, so I don't think there's any one that we might trust more than the other. They look so similar. So let's pull up one single topography. And what do you see? This is an axial interpretation. You see your axial power selected here. And what did we say axial is good for? Axial tells you refraction. So how does the anterior surface shape of the eye contribute to vision? And this is certainly our with the rule astigmatism. It's obvious to see from our figure 8. It's very symmetrical within the pupil. That's a mirror of that. That is a mirror of that. So correcting this patient with spheral cylinder refraction, going to be pretty easy. This patient may not need a GP lens. This patient might do well with a soft toric because the eye is so symmetrical, and the axial map tells us that. Actually, this patient wasn't successful in soft torics because this patient had a high amount of rotation. So we ended up fitting this patient with a GP lens. Had good vision when the lens was stable, but when the lens was rotating, not so good. So we ended up going GP. Now, what else can we learn about this eye? Is it apical astigmatism, or is it limbus-to-limbus astigmatism? And you see the hot meridian running from one side of the eye to the other. So right off the bat, that tells me we've got a high amount of central corneal sill, 2.5 diopters, but we also have a high amount of peripheral corneal astigmatism. So what's another way we could look at that? Let's think about that sagittal depth factor that we were talking about. And if we were to take a 9.5 diameter GP lens, its optic zone would typically be around 8 millimeters, 8.1 millimeters roughly. So 9.5 diameter lens, optic zone at about 8 millimeters. So where the lens bears is at the optic zone junction, around 8 millimeters. So let's set our chord at 8 millimeters and look at the flat meridian. Let's click our cursor on the flat. And the topographer says there's 1,063 microns. So the height of the eye is 1,063. Now, how does that compare to this limbus-to-limbus meridian, this steep corneal meridian? So when we click our cursor on the steep and measure the sagittal depth, we're 1127. So it was 1,063 versus 1127. So if I did my math right, there's 64 diopters of difference between the horizontal meridian and the vertical meridian. In other words, there's going to be 60 microns of fluid underneath the spherical GP if we put that lens on eye. So let's do that. Let's see if this patient is a candidate for a spherical GP lens. Now here's your contact lens software, and we'll start by selecting the diameter that we want to apply. And we pick up our contact lens and place it where we think it's sitting on the geometric axis. If you were looking through a slit lamp at this lens, would it appear centered to the visible iris? That's the first question. So we've done that. We've dropped it on center. Now let's click our cursor in the center. The number one thing we teach our students at Pacific, the first thing you look at when you look at a fluorescein pattern of a GP lens is, does it clear the corneal apex? Does it appropriately clear the corneal apex? Is it bearing? Is it excessively lifting? So number one is, what have we done in terms of base curved cornea? And when I click my cursor in the center, it says we have 22 microns of fluid underneath that lens. What did we say was our minimum threshold to see fluorescein? 20, right? So we've now met that threshold. If we were to drop this lens on eye, it should have some visibility of fluid, of fluorescein molecules under the center. So this is good. Now the next question is, we've cleared the corneal apex appropriately, but where does the lens land or bear? So look at the graph down here and observe the fluid as we drag this axis line around. Let's find the axis of most bearing. So when we take this around to the horizontal meridian, the flattest corneal meridian, you can see your lens seems to kiss down at 9 o'clock and kiss down at 3 o'clock. So this is good. We want our students to build lenses to have this, landing at 3 and 9 o'clock, where the lens sits on these rails and it can only move in the vertical meridian. It can only move in the vertical meridian if we have a channel for it to freely move. So let's see if we actually have that channel. So we'll drag this to the meridian where the fluid seems to be the thickest on the graph, and it's somewhere in here. So notice, if I click my cursor up here at the superior optic zone junction, the inner pink circle is the optic zone. We measure 55 microns, and we set a bubble's created at 90, so we're a little more than halfway to creating a bubble. When we go south, we're at 68 microns of fluid. So you can imagine this lens has a lot of ability to tilt and rock back and forth. And that's because we're putting a spherical lens on a 2.5 diopter corneal astigmat that also has limbus-to-limbus astigmatism. So this lens is going to be tough. We're going to have a tough time making a good go of this. Having the lens stable, having the lens comfortable for the patient, and maybe creating stable vision too, because if it's moving excessively, this optic zone junction may just keep kissing the pupil margin. So another way we could look at it is, let's pull up the elevation map, and we talked about that earlier. Axial says the eye is curved here and here, but is this elevated? That's the question. Are these high points? What is the highest point on the eye if we were to drop a rigid lens on? Now, putting the theoretical lens on, it says that's a high point, that's a high point, that's a low point, that's a low point. Utterly opposite to what the map is telling you, right? The map says the cornea is blue, it's flat. It must be low. The cornea is red, it's steep, it must be high. But that's not what your contact lens is telling you. Let's pull up the elevation map though. And notice what the elevation tells you and how identical this is to this, isn't it? Red, the cornea is high in elevation. Theoretical contact lens, points of bearing, same exact position. The map says blue, that's the eye depressing. The eye is dropping in elevation here and here, and that's what we're seeing in our contact lens, vaulting here and here. So really awesomely correlated, those two, the elevation map and the theoretical contact lens. So what if we were to take that lens that we designed and drop on the actual lens? And here it is. So rule number one for our students, did the lens clear the corneal apex? And when we click our cursor in the center, it says that we should have 22 microns of fluid, and what we're seeing in the center is definite fluid clearance, aren't we? So our lens has appropriately cleared the cornea. Our lens is landing at 3 and 9 o'clock, which we predicted it would. Our lens has this fluid channel across the vertical meridian, and of course the problem is with that steep limbus-to-limbus meridian, the lens wants to decenter up, doesn't it? And this lens, if you saw it moving, moved excessively. Patient was very aware of it. So what do we need in this case for this patient? What would be a much better option? Toric, right? Let's go to a toric lens. So let's pull up that lens again and pull up the parameters. And we'll click on toric. And this may be hard to see, but we've got two base curves now, a flat meridian and a steep meridian. And what we want to do is drop that toric on eye and treat this exactly the same as the sphere. First thing is we click our cursor in the center and it says we have 17 microns of fluid. And we know when we're below 20 microns, the density of those molecules isn't such that we're going to be able to pick them up. So in other words, we can't say the lens is definitely clearing the corneal apex and we have a healthy relationship. So we must steepen up the lens to get this lens off or above our threshold to pick up fluorescein. So I'm going to steepen the two base curves a quarter step, one step, and now we're up to 27 microns. So rule number one that we teach our students, have appropriate apical clearance, and we've met that. So now the next question, rule number two, is where does the lens land, where does it bear? So let's take this white axis line and drag it around and find the axis of most bearing. And it appears that I'm landing somewhere around 1 o'clock and 7 o'clock, and you see that here. That's 7 o'clock, that's 1 o'clock. This doesn't look good, does it? Now our contact lens is bearing like it's an against the rule stigmat, and we've got this channel running across the horizontal meridian. There's nothing to hinder the movement of the lens across the horizontal meridian. So let's tweak this, let's fine tune it. The blue line here is your flat corneal meridian, and right now the lens is lifting off at 3 and 9 o'clock. So let's take the flat meridian and steepen it up one step. Now in the vertical meridian, our lens appears to be bearing, so it's effectively too steep. So let's flatten it off and allow for that channel. So let's take the steep meridian and flatten it off a couple steps and apply. And now what do we have? We take our axis line to the horizontal and we have good landing at 3 and 9 o'clock. We take our axis line to the vertical and we have that nice little channel running all the way across the lens. So let's put on the actual lens that we designed from the software. And there's your same patient with now the bitoric lens, not the spherical GP. Lens wants to center, lens is far more stable, lens is far more comfortable, vision is more consistent. So we use the theoretical software to build the lens. And this is one of the powerful things about the software is if you don't want to do all these maps, if you don't want to design all these lenses, if your practice is too busy to be playing around with the lens diameter, the optic zone, the apical clearances, you just highlight the maps that you want to send to Valley, go up to the Medmon icon, select export, and this is patient, let's presume Smith, and we'll save it to our desktop. Then when we create that little export file, this little this little file here has all 8 of those maps, the 4 rights and the 4 lefts. We send it off to Valley, and they're able to import it into their MedMod software. They can manipulate it the same way as if they had taken the maps on the patient here, and they can manipulate it, go from axial to tangential to create the theoretical lens. They can manipulate it the same way as if they took the topography themselves. So a great way that you can communicate more information with your lab, with Valley, than just sending central corneal K readings. We're able to build the lens in terms of this elevation. Now, what about the diseased eye? What if we were to take a patient like this, keratoconic eye? Is this a patient that's a good candidate for a corneal GP, or do we need a scleral lens for this eye? So let's pull up the software and grab, let's say, the Valley iCone lens, and let's see if this is a good candidate for a corneal GP, or should we go with one of Valley's scleral lenses. So we'll put the lens on the center of the eye, centered to the iris as we would like to see it, and click our cursor in the center, and the lens that the software defaulted to has 203 microns of clearance. And what did we say we want optimally? Somewhere in 20 to 30 in a normal eye, maybe in a diseased eye a little bit more, maybe 30 to 40, because if the cone is going to change, we want to allow for a little room for it to maneuver. So let's create a flatter surface and see if we can get that lens to drop itself down. Now, by going to a 675 base curve, we get down to 136 microns. If we were to go down to a 734, down to 74 microns. Let's go to a 767, down to 35 microns. So this is good. Now we're in that target of the 30 to 40 microns that we want on a diseased eye. Normal eye, 20 to 30. So this is good. We now have an appropriate apical clearance. Let's look at where the lens bears. So let's take this axis line around and look at the fluid underneath the lens. And it appears that it's going to land at 830 right here and at 230 right here. So this is good. Our lens will sit on the rails. It should be laterally stable, and therefore we should expect it to have hope of centering at least laterally. Now the question is, how much fluid exists in the vertical meridian? So let's take the axis line to the vertical and look at the fluid layer. So heading north, somewhere in here, we're at around 70 microns of fluid. So we're below our 90 microns that would create a bubble. Heading south here, let's click our cursor right here. We're at 125 microns of fluid. So certainly a bubble could form underneath that lens. Should we fit a corneal GP or a scleral? If this was a deep set eye, I would go to a corneal GP because it looks like it might have some hope. We've got some good landing at 3 and 9 o'clock. We can create a nice relationship. If you take that white axis line to the axis of most bearing, look at this beautiful edge lift landing, apical clearance landing, edge lift. It looks to me like it has hope, at least across the horizontal. The vertical meridian, it could be problematic. We may get a bubble down here. It may be lifting off so much that inferior lid may just grab the lens and want to pop it out. But because there's hope, I might try a corneal GP. Again, if scleral didn't look like it was going to be possible. If we had a real small deep set fissure, small fissure patient with a real deep set eye, maybe scleral wouldn't get in there, so corneal GP would be the right call. Have a look at this same patient's fellow eye. Central keratoconus, to me, when I see that, I think should be fairly straightforward. Because the cone is so centered, then I'm hopeful that I can align the lens around here, 360 degrees. But let's pull up the theoretical contact lens. Let's put on the iCone again and pick up our contact lens, put it on the geometric axis, click our cursor in the center. We have 122 microns. So let's choose a flatter base curve to get this down to around 35 microns, or 30 to 40 microns. There's 31. So this is good. Now we've got the appropriate apical clearance, lens landing at 3 and 9 o'clock. That's good. But look at the vertical meridian here. If I click my cursor here, we're 126 microns right there. How about down here? 203 microns of fluid here. So I think in this case, it would be a waste of time to put on a corneal GP. Let's just go straight to a scleral lens. So what we might do then is grab the map and put on a scleral lens. Okay, and let's just change the fluorescein for a scleral, because we're now dealing with not 100 microns. With a scleral lens, we're dealing with upwards of 100 microns of fluid. So here's our theoretical lens, and what you're looking at is if we take the white axis line to the horizontal, we click our cursor in the center, it says we have 470 microns of fluid. We teach our students at Pacific to start with approximately 400 because we know scleral lenses can sink into the boggy conj by up to 250 microns. So if you start with 400 and it sinks 250, we're still left with 150 microns of fluid. If the lens sinks by only 100, 300 microns, we don't see any problems with patients having that much fluid under the lens. So our feeling at Pacific is more is better. There are other trains of thought as it comes to scleral lenses, but that's just how we approach it at the university. So let's back this lens off a step to get a little less clearance than 470. And now we have, whoops, I went the wrong way. I went more depth. I want less depth. Apply. Now my lens has 367 microns to start. So the next question I might ask is, I've got a trial lens that probably will have a good starting point for apical clearance. What about the limbal clearance? And this patient, if we presume, let's actually measure, just so we're 100% sure what the visible iris diameter is. So let's run a ruler across this visible iris, and we ignore the colorized map and find that white, gray, or white iris border, this white to white measurement. And this eye comes up as 11.8 visible iris diameter, and absolutely right in the middle of the bell curve diameter. And let's put our scleral lens back on. Okay, so at around 12 millimeters out, this is the limbus, and we are in the neighborhood of almost 160 microns there, and on the nasal side, somewhere in the neighborhood, temporal side, we're somewhere in the neighborhood of 240 microns. So we've got lots of limbal vault. This is looking good. We don't expect this patient has one of those weird high angles like I have, where I'm going to be a real elevated point near the limbus. So the standard lens probably looks like it has hope. Now, scleral lenses don't sit up high and proud like this, with this landing on the surface way up on top of the conj. And with those big goblet cells, those lenses just sink right in. So using this little theoretical model is really only helpful in terms of picking a lens that might start with the right apical clearance. So what if it settles? Why don't we do that? Why don't we settle the lens by the average amount of settling? Let's put 150 microns of settling in and have that lens sink in. And notice how the topographer is now allowed, the model has allowed that lens to sink as it would normally into the boggy conjunctiva, sink in out there and observe, does it appropriately clear? Does it still have the right clearance? And at 6 millimeters on this side, we've got still in the neighborhood of 80 microns. At 6 millimeters, at the limbus out here, we've actually bared in. So we might need to adjust these parameters in our custom order. So let's do that. Let's change the landing of the lens out there and vault this area up so it appropriately clears the limbus. So hopefully that gives you some perspective on how you can use the topographer both to fit corneal GPs and to fit scleral lenses as well. Now, I'm going to finish up with this last slide and thank my colleagues at Valley Contax for inviting me out and letting me share with you guys some thoughts about corneal topography. There are a number of videos available to you that you'll links to YouTube videos that talk about each one of these sections that we talked about: disease detection, axial versus tangential, elevation maps, contact lens design in corneal GPs, scleral lenses, and you can get these links from Valley Contax if you want to learn more about the instrument you have, or just to learn more about how to use topography in general, not specific to the MedMon. So thank you very much, Valley, for having me.
Thank you, everyone. Thank you, Randy.